other flow rate. So when this patient exhales out, this ends up, because it's a steady state here, so this volume from here where they began to exhale up to here is a particular volume. And it might be, let's just say it's 4 liters, okay? So 4 liters, what's 25% of 4 liters?
1.
1 liter. So if you go up this curve and you measure 25%, and then you go, what's 75% of that 4 liters? 3.0 liters, so maybe it's over here. So we've just plotted out where the flow is, the volume within 25% and 75%. This becomes a measurement, FEF 2575. It's characterized as the middle 50%. So the middle 50% is a flow rate between connecting these two spots. 25% and 75%. It happens to be the middle 50%. And the middle 50% is a characterization of the flow coming out of the small to middle airways. So if you're wondering about how flow is coming out of the 16th, 15th, 14th generation of tracheobronchial tree, how the air is coming out, the middle 50% is representative of the middle to smaller airways. And if that FEF 2575 is reduced, that would mean restrictive lung disease, but more particularly, we know that there's obstruction of the middle to smaller airways. That's important if you know that the problem is in the middle or the smaller airways, because then you can target those airways. We target them with bronchodilators. Usually we see the first evidence of lung disease is usually a reduced 2575, an FEF 2575. So it means that the middle to smaller airways are obstructed and they're affected. Would a patient necessarily notice any difference in flow going in and out? Probably not. But it could be measured. It's part of the minute data that's measured in a PFT machine that becomes the first clinical objective evidence that the middle to smaller airways are affected by either asthma or bronchitis or emphysema, or so it becomes the first thing that's recognized on a PFT that indicates obstructive lung disease, an FEF 2575. So it's the middle 50%. It represents the smaller airways because it's 50%. It's the area where the middle 50% is represented on an exhaled maneuver, right? So the middle 50% represents the smaller to mid-sized airways. It's usually the first one affected. Another measurement is an FEF 200-1200. So 200 milliliters is down here. So if this is 1.0, this is 3.0, right? 75% of a 4-liter vital capacity. If the 200, so if we go up 0.2 liters to, what's it, 1.2, 200, 1200. So 1200 is right about here, 1.2 liters. So from here to here, if we look at the average flow rate of the 200 to 1200 milliliters, so the 2575 was 1 to 4 liters. The 200, 1200 was 0.2 to 1.2. It's measuring, it's telling you where they're measuring the flow rate. The flow rate between 200 milliliters and 1200 milliliters. Well, that represents the larger airways. It represents probably the main stem, the first 4 or 5 generations. So the beauty of that measurement is that it's telling you where the obstruction is. If you can look at 200, 1200 versus 2575, it's the difference between the larger and the smaller airways, and you can pinpoint where the obstruction is occurring. If you have a reduced 200, 1200 versus 2575. Does that make sense? FEF 200, 1200, larger airways. FEF 2575% is the smaller airways. So that's pretty interesting if you can be diagnostic in where the obstruction occurs, right? You know it's in the smaller airways if it's the reduced 25-75. It's in the larger airways if it's at 200-1200. 200-1200 is just beyond dead space, right? How many cc's is dead space? First 150. So 200 would be just beyond the trachea, the main stem, maybe 3 or 4 generations. So where you're actually measuring at 200 milliliters, you're measuring generation 5 or 6 down to about 15 or 16. Whereas 25-75, you're measuring 10 or 12 or 14 down to about 16 or 17 or 18. Larger versus smaller airways. Is that powerful stuff if you can tell a physician, well, he's kind of obstructing those smaller airways based on the FEF 25-75. Oh, how did you do that? Well, I did a PFT. What did that tell you? It told me that there was a reduction to airflow because of reduced FEF 25-75, right? Pulmonary function test. Powerful information, stratified data that looks at a single breath, and it breaks it up into all these different pieces that you can then be diagnostic. And you can tell what's going on with the flow coming out in relation to the volume that it measures altogether. But it's doing it, it's stratifying it in one breath, one measurement. But it's only as good as the practitioner who's gathering that data. You have to coach and encourage your patient. You have to sometimes be a little bit boisterous and, you know, take a deep breath and blow, 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 blow. I mean, really tell them and show them what to do. In the ER, you often do another flow rate, a measurement called the peak flow, PF, or sometimes you'll see it PEFR, peak expiratory flow rate. So patients that have asthma, we sometimes do peak flow rates. You might have done this in lab. Take a deep breath in. It's just one burst of air. It's the peak expiratory flow rate, and it's measured in liters per minute. So the difference between some of these measurements is how they're measured, liters per minute. These flow rates, the FEF 25-75 and the FEF 200-1200, are measured in liters per second. So all you do is you take a flow rate and divide it by 60, right, to get liters per second. So a peak expiratory flow rate is measured in liters per minute, usually a flow rate of around 300, 400, 500, 600 is average, depending on age and height and sex. Again, we're still stratifying it by people of like conditions. So that peak expiratory flow rate, or a peak flow, is measured in liters per minute. Number you might see is 300 or 400 or 500. If you divide that by 60, you could get a peak flow rate, or a peak expiratory flow in an FEF 25-75 or an FEF 200-1200, measured in liters per second. PEFRs measured in liters per minute, peak expiratory flow measured in liters per second. So you'll begin to recognize those differences in the data that we get. So peak expiratory flow rate. So on the next couple pages, they talk about forced expiratory flow rates. So if a patient's able to breathe out, so this is a normal patient with a 4-liter vital capacity, right? So what do you think a patient would do if they had restrictive lung disease? They had kyphosis, pneumonia, things that reduce their volume. So they'd exhale that air out. It would be fairly consistent, but it would be a lower volume. The diagram that looks at flow rates particularly, you look at flow rates, and in obstructive lung disease, basically, this is a flow rate, how fast it comes out. So it would be down like this. But over time, over 5, 6, 7, 8, 9, 10, 11, 12 seconds, 10 or 12 seconds, it would eventually even out. But the tracing really represents how they're not able to get the air out. Where the flow rate is reduced. Eventually, 10, 11, 12 seconds, it gets up to 4 liters, but it takes a long time to get the flow out because of obstructed airways. So that's what you're seeing represented in the text, is why these things are lower, because the flow rates are reduced. So flow, and then these things, see how they're lower? It's because you can't get the air out. That's measured on a spirogram, measuring spirometry. Okay. Last part of the chapter talks about dynamic compression. And it's showing you on page 166 and 167, it's showing you the difference between obstructive and restrictive flow volume loops. So if you measure flow, so you take a deep breath in, exhale. So this is inhalation down here. This is exhale. So from this point, you begin to exhale. The result of an exhalation and an inhalation is a flow volume loop, or sometimes they call it a flow volume curve. So generally, if volume is along this axis, this is volume, and this is flow going up this way. So depending upon how much comes out, a restrictive lung disease, restrictive would look like this. So I can look at that and I say, oh yeah, that's restrictive lung disease. The volume's just not there along the horizontal axis. If it's obstructive lung disease, the patients will exhale, maybe not quite as fast because the flow is reduced. It'll look like that. This dip in this exhalation, this flow rate, is what's described as that's an obstructive pattern. So that's restrictive, that's normal. Is there an obstructive pattern?
Back.
Yeah. So just by I don't have to know numbers. I don't have to attach any meaning other than just the shape of that flow volume curve, and I should be able to tell lung mechanics and whether or not this is obstructive or restrictive lung disease. We can tell just from the shape. Restrictive, showing low volumes. Obstructive, like the little depression in that exhaled curve, shows obstructive lung disease. And it's diagnostic that quick. I know on the national board exam, they show you a flow volume curve, and they'll ask you, is this obstructive or restrictive lung disease? You can tell just from the shape and pattern. It's that simple. It's that simple, just recognizing what a restrictive lung disease shows and what the obstructive lung disease shows with that depressed, exhaled curve. Very specific, and I guarantee you'll see one on your national board exam. They'll ask you to diagnose a PFT with an obstructive or restrictive defect and actually identify, is this restrictive or obstructive? Guaranteed. Yeah, this one's normal. So it's just pointing out all the different beams that you can get on there. There's the FEF 200, 1200, there's the peak flow, there's the 2575, and then the FEV 1, 2, and 3. Cool. So you can actually see it represented on this flow volume loop. That's the amazing thing of that graph is. And that when patients are on mechanical ventilators, you'll see graphs of inhalation and exhalation. You can do flow volume curves of every single breath on a mechanical ventilator, that you can see the mechanics of how the air goes in and out. It's amazing. So the technology and the data that you have available to you at your fingertips, at the bedside, can be instantly diagnostic, and you can use that to your advantage to make it as easy as you can for any patient on a mechanical ventilator. It's crazy, but it's as easy as that. So the table on the bottom of 166 gives you some examples. Basically, we've shown you that when we forcefully exhale, at the end of expiration, the more I compress, the more I put into effort to get air out, what happens to my airways? They're compressing even more. That's called dynamic compression. So in COPD patients, dynamic compression happens sooner, and it happens further upstream. I think Desjardins says downstream. I think what he means is it's further down in the airways. But what happens is in COPD disease, the obstruction occurs sooner. And so there's more of a compression that we don't get the air out. So as hard as I can push, the more muscular effort I put into it, how much flow comes out? Diminishing amounts, decreasing amounts. So dynamic compression is a concept that by increasing muscular effort, the more muscular effort that goes into it, the less flow comes out of it. That's dynamic compression. And in disease states, it moves further upstream, which reinforces the idea that obstruction of these airways occur, that it's a three-dimensional structure, that there are alveoli in front of and behind every airway, and that by hyperinflating one alveoli, it puts pressure and compresses the airway behind it. So remember, the lungs, we draw it as a single cell, a single saccular unit, but it's really 150 million on each side, inflating and deflating dynamically and affecting the airways of the other adjacent alveoli. And that if we hyperinflate a few alveoli, it influences how we get the air out, and the patients adopt patterns to breathe as easy as they possibly can. We try not to use effort to exhale, because exhalation is relaxing, right? On deep inspiration, we've contracted the diaphragm. When we exhale, it occurs through relaxation. We relax the diaphragm. But patients with obstructive lung disease, what do they end up doing? They use their diaphragm to forcefully exhale the air and to contract and use muscles to get the air out. Okay? That's because of the obstructive nature of disease and how they use their accessory muscles then to get the air out. Okay? So dynamic compression of the airway. At some point there's an equal pressure point. I think the text tries to point that out. The equal pressure point. It's when the inside of the pressure reaches what's exerted on the outside. And that in COPD then the equal pressure point moves further or closer to the mouth. Some different measurements, DLCO, diffusing lung carbon monoxide. Sometimes we'll use a DLCO to measure how, essentially, the integrity of the alveolar capillary membrane. What do you know about carbon monoxide? It's 250 times soluble in the human body than is oxygen. So on the hemoglobin molecule, it'll replace oxygen. It'll preferentially pick up carbon monoxide. It's 250 times greater affinity for hemoglobin than oxygen. So if you have an oxygen molecule and a carbon monoxide molecule, the carbon monoxide molecule preferentially combines 250 times stronger. So if we expose a patient to carbon monoxide, we want to see how rapidly it goes. Here's our alveoli. If we put carbon monoxide in there, we want to know how fast it gets into there. That's called the DLCO. It's how fast we diffuse carbon monoxide. And it's a measurement, it's an assessment. A DLCO is a measurement of the integrity of the alveolar capillary membrane. If there's fibrosis or scarring or fluid, then we won't diffuse as much carbon monoxide. If there's a problem with the integrity of that membrane, it won't diffuse across. Make sense? Mm-hmm. Because it's so efficient in combining to hemoglobin that if there's any problem with the alveolar capillary membrane, it won't diffuse across there, and that number will be lower. So that's called the DLCO. And we sometimes use DLCO to look at how well that membrane functions. We'll learn next chapter that the membrane itself is 9 tissue layers, and we'll be able to identify where those tissues are. we measure something called the maximum inspiratory pressure or maximum inspiratory force. If we were to close your nose and your mouth and then breathe in, you're creating pressure. You know, the diaphragm's contracting, and by taking a deep breath in, contracting your diaphragm, you're trying to bring air in from the environment into your lungs, right? So that's negative pressure. It's a reflection of the pleural space. How much negative pressure is generated. We should be able to generate minus 75, minus 80, minus 90 centimeters of water pressure. Patients with difficulty breathing, neuromuscular disease, myasthenia gravis, Guillain-Barré, ALS, they have decreased muscular ability to contract their diaphragm. And we can measure that. That's called a NIF, negative inspiratory force, a NIP, negative inspiratory pressure, maximum inspiratory pressure, MAP, MAP. Sometimes you'll hear MAP as a mean airway pressure too. But the point is that it's measuring, it's an assessment of how strong the muscles are to breathe in, a MIF. Negative inspiratory force or a maximum inspiratory force. You're measuring it in pressure. And when babies breathe in, the first breath of life, they have to open up all those little alveoli, and they have to generate pressure to contract the diaphragm, expand the pleural space, and get air into every closed alveoli, overcoming the surface molecular force of water keeping them closed. They have to generate huge pressures to pop those things past critical opening pressure and get them open. Okay, the last test is called the Shallow Rapid Breathing Index. Have you heard of that before? An RSBI, Rapid Shallow Breathing Index, RSBI. So an RSBI is if we breathe rapidly and shallowly. So what if we breathe 150 cc's 60 times a minute? How much of that air, first of all, is effective getting down to the alveoli? None of it, because it's all breathing dead space, right? But it's rapid and it's shallow breathing. So there's a number that we usually indicate to measure a patient's readiness to be able to be weaned from mechanical ventilators. And that we use RSBI as one of those assessments. So rapid shallow breathing index is a number. It should be less than 100. So in other words, if I'm breathing 300 milliliters, it's an average type.